So, good evening, friends. This is Dr. Rutvik Trivedi, your friend and a cardiologist, and we are here to discuss about the heart failure. And this is our almost third talk on the heart failure. And today we are going to discuss some basic aspects of heart failure management strategies. And I just want to request you that whatever information has been shared with you via this medium is for your basic understanding. Your cardiologist or the doctor or the physician who is treating you is the one who will decide the medication strategy of heart failure on the basis of your hemodynamic data and other comorbidities. This is for understanding and knowledge and awareness regarding the heart failure. So don't argue with our doctor that I know this much or I've been taught this much or this is what I have learned from another doctor. So coming to the basics of heart failure, and in the first talk, I told you about what is heart failure, and just to recapitulate that heart failure is inability to of the heart to pump the blood uh, as per the requirement of the body. This is called as heart failure with reduced ejection fraction, and there is another term which is called as a good pumping heart failure. That is heart failure with preserved ejection fraction, where the heart's pressure and volume handling capacities are altered, and both the condition will give rise to a similar situation. And the symptoms we have already discussed, that is a breathlessness, easy fatigability, orthopnea. I have told you what is orthopnea. Paroxysmal nocturnal dyspnea, patient suddenly gets up after 2 to 3 hours of sleep. Patient coughs. The cough will be of pink with a pink sputum. There can be pedal edema. There can be abdominal distension and easy fatigability with lot of perspiration. So these are all symptoms of heart failure. I also discussed about the various types and stages. Types I have discussed: preserved, mid-range, and reduced ejection fraction. Stages of heart failure are stage A, where you have risk factor. Stage B is where you have a damage already occurred in the heart, but you have no symptoms. Stage C is when you have symptoms and you have a changes in the heart. And four will be a refractory heart failure. Investigation part, we have discussed last time that there are some basic investigation. We look for anemia, we look for your iron levels, we look for a specific biomarker which is called as NT-proBNP. If it is a heart disease, your doctor can prescribe few more tests that includes kidney function, troponin levels. They may advise you angiography. They can advise you a cardiac MRI, and utmost important is basic investigation like ECG and echo. And on echo we'll get a lot of information, on ECG we'll get a lot of information, and on that basis, once your diagnosis is confirmed, then they embark or start few medications. Now, which are these medications to be given in patients of heart failure? Now we'll discuss one by one, and we'll also try to understand what is needed in specific cases. So first we take an example of a patient who is having heart failure, he's having hypertension, he's having diabetes, but he is having no coronary artery disease. That means કે હાર્ટ में अभी ब्लॉक हुआ नहीं है, नली ब्लॉक नहीं है, હાર્ટની નળીઓમાં બ્લોકેજ થયેલો નથી. So for that patients you need one drug which is for blood pressure, one drug for the diabetes, and few more medications that will control your pressure symptoms. Now, which are these drugs? So important four pillars which are mentioned in the management of heart failure. So starting with a drug which is for symptom relief, and starting with the drugs uh, which are basically meant to reverse the process of dilatation. જે હાર્ટ પોળું થઈ ગયેલું છે એને એટલીસ્ટ સ્ટેટિક કરે અથવા તો એને વધુ પોળું થતું અટકાવે. સો સિમ્પટમ્સ રિલીફ માટે પેશાબ કરવાની દવા જનરલી આપતા હોય છે અને એને કહેતા હોય છે ડાયુરેટિક. સો એક વન ઇઝ અ ડાયુરેટિક. સો ડાયુરેટિક્સ કેન બી લેસિક્સ or torsemide. Most of the time they are prescribed, and that again depends upon your kidney function, your hemodynamic status. But generally, once the diagnosis of heart failure is been established, these are the drugs, group of drugs, as I mentioned, it is called diuretics to be prescribed. Secondly, if your pressures are very high, then to control the pressure, blood pressure reduction agents, which we call as antihypertensive or few drugs which are called as vasodilators, એટલે કે નળીઓને થોડું રિલેક્સ કરે કારણ કે નળીઓ are in a constricted phase. So that drugs are prescribed and generally it is a nitroglycerin drug. However, your cardiologist or a treating physician can use another drug for a same situation, but this is a basic standard protocol at my institute and in most of the part of the Gujarat. So symptom relief, emergency treatment, these two drugs are mandatory. Once you are stable, your diagnosis is reached, suppose you are having coronary artery disease, apart from this medication they will give you antiplatelet statins. If you are diabetic, they'll start you with the insulin preparation and then switch to oral medication. Now you are stable and then you are at the stage of discharge. So once you are at the stage of discharge, we generally prescribe 4 medications or you are on a regular OPD follow-up. So one drug is a beta blocker. So beta blocker is a drug which basically acts in various ways, but the important basic mechanism of beta blocker is to reduce the heart rate, reduce the blood pressure, reduce the contractility of the heart. એટલે આ બધું શું કરે છે? Reduce કરે છે. Reduce કરે છે એટલે એનું કામ ઓછું કરે છે. કામ ઓછું કરે, that means the oxygen requirement is less. So there will be a less oxygen requirement and that will give rise to symptoms relief. જે બી symptom relief થશે એ એને લીધે થશે. Secondly, હાર્ટ નું કામ છે બીજા અંગોને બ્લડ પૂરું પાડવાનું. સો હાર્ટ ને પોતાને ક્યારે બ્લડ મળે છે તો કે જ્યારે હાર્ટ રિલેક્સ કરતું હોય ત્યારે, એટલે કે ડાયસ્ટોલ ની અંદર જ્યારે હાર્ટ નો રેટ વધારે રહેશે ત્યારે હાર્ટ ફાસ્ટ બીટ કરશે અને એમાં એને પોતાને ફિલિંગ થવાનો ટાઈમ મળશે નહીં, અથવા તો પોતાને પરફ્યુઝ કરવાનો ટાઈમ મળશે નહીં. સો બાય રિડ્યુસિંગ ધ હાર્ટ રેટ યુ આર ઇન્ક્રીઝિંગ ધ ડાયસ્ટોલ એન્ડ ધેટ ઓલ્સો ઇમ્પ્રુવ્સ ધ coronary feeling, and that is also one of the mechanism that give rise to a symptom relief and LV remodeling. અને એટલી બધી નાની નાની minute anti inflammatory actions છે, endothelial dysfunction prevention ની actions છે. So these are all very scientific and medical terms and we will not discuss that into much detail, but basic understanding is a beta blocker has to be there in the management of the heart failure. Except you have allergy to beta blocker or your heart rates are very low, you are not tolerating, or you have some lung pathology and your doctor feels that it is not to be given in that condition, will not give rise to beta blocker. So heart rate reduction માટે beta blocker જોઈશે અને target heart rate તમારો 60 to 70 વચ્ચે લાવવાનો પ્રયત્ન કરશે. So if your heart rate is 60, don't worry, oh my heart rate is 60, that is what we want to achieve, and during sleep it may go to around 55 to 60, maybe 50, but you are asymptomatic, so don't worry on that part. A lot of people, they come to me and complain about that my heart rate is low, that has been told by their general practitioner or on monitor. So this is what our goal is, to achieve a lower heart rate. Generally by means of lower heart, what is the meaning of lower heart rate? It is in between 60 to 70. Ideal is around 60 to 65. So higher the heart rate, higher the mortality, and that is what is been studied in various studies, and that is why we try to control the heart rate. So that is one thing. Second group of drugs we give to our patients are ACE inhibitors slash ARBs slash ARNI. So these are the group of drugs, they are basically meant for the blood pressure control. Now you will say, I don't have a blood pressure, or many patients they ask me, but still you are giving me this medication. So one action is they will reduce the blood pressure if you are hypertensive, but you are normotensive and you have a heart failure. So in that condition we'll still try to lower the blood pressure because it will reduce the burden on your heart. So this drug will act as they act in the hypertensive patient. They will vasodilate the constricted vessel, જે artery constrict થઈ ગયેલી છે એને vasodilate કરશે. Vasodilatation થશે એટલે heart ને easily pump કરવા મળશે, because vessels are constricted, he has to work against a force and that will lead to a more work, and because the heart is failing, heart's capacity is less, it will immediately get fatigued and you will have a symptoms. So once you vasodilate karso, relaxation karso, cardiac pumping will be good. So second group of drug, as I mentioned, is ACE inhibitors slash ARB slash ARNI. So beta blocker, second is vasodilators, oral preparation. In acute condition, as I mentioned, NTG or some form of vasodilators they give to control the blood pressure. So that is during an acute phase. In a chronic phase or during your regular APD visits, they will give you oral preparation, which I already discussed. Third group of drugs are the newer drugs and which are now become a cornerstone in the management of the heart failure are the SGLT2 inhibitors. Now, why I stress this drug called SGLT2 inhibitors? Because few years back, these are the drugs they've been tested in a diabetic patients. In diabetic patients, they will reduce the blood sugar, but later on, because it's a unique action, it will basically causes glycosuria. Urine ma sugar java dese. So urine excretion will be glucose excretion will be more in the urine, and in that action, it also allows the water to be removed from the body. So glucose જોડે પાણી પણ જતું રહેશે એટલે diuretic ની actions પણ થશે. It has a different mechanism. એ નળીઓ બી રિલેક્સ કરશે, હાર્ટનું પમ્પિંગ કેપેસિટી છે, હાર્ટની અંદર જે સ્ટ્રક્ચરલ ચેન્જીસ આવેલા છે, all the things will be altered. So even though it is meant for a diabetic patients, in normal patients, normal sugar patients, if you give this medication, it will not produce hypoglycemia. So if you encounter, or today only I had a patient who said that I don't have diabetes and you have prescribed me this medication which is meant for diabetes. I asked who told you this? They said that pharmacist told me this. So if your pharmacist tells you that this is a diabetic medication, if it is an SGLT2 inhibitor, so don't worry on that part. It is a very important drug for the management of the heart failure. Fourth group of drugs are those drugs who will maintain your potassium level in the body, because as I mentioned કે symptoms control માટે તમને diuretics જોઈશે. That will again cause more water excretion, and in that action there will be a loss of various electrolytes like sodium, potassium and magnesium. Now magnesium per se is very important, that too particularly in a heart failure patient. So aldosterone antagonists are the potassium sparing drugs. They are given in the patients. So apart from retaining the potassium in the body, it has various actions, and via these various actions, it improves the contractility and reduces the hospitalization for the heart failure. So the aim of management in the heart failure patient is decrease the mortality, that means the death rate, and decrease the repeated hospitalizations. If you take an average, if you take an data, Indian data for the heart failure, once a patient has been diagnosed with the heart failure, around 16 to 25% of the patient, they had a mortality at 1 year, and approximately 35 to 40% of the patient had a repeated hospitalization for the heart failure during 1 year. To compare the Western data, the death rate, Western data it is only 5%, and repeat hospitalization only 15%. So Western ma bhi repeat hospitalization to major problem change, and Indians ma it is 40%. So it's a major issue. So these drugs, as I mentioned, beta blockers, vasodilators, as I mentioned, ACE inhibitors, ARNI, ARBs, SGLT2 inhibitor, which are basically initially started for diabetes, but now they are the drug of choice in heart failure, even though they are not diabetic, and aldosterone receptor antagonists. So these drugs are a part of a standard guideline directed medical therapy regime for the management of the heart failure. Now, these all medications which I spoke to you are basically for those patients કે જેમનું પમ્પિંગ ઓછું છે, જેમનું પ્રિઝર્વડ પમ્પિંગ છે, એમાં ટેલર મેડ એપ્રોચ જશે. Again, diabetic medications, hypertensive medications, beta blockers are definitely going to be there. Now, there are few challenges to this, that if your patient had a comorbidity, because say lung pathology છે, તો ઘણા patients માં beta blocker tolerance નથી આવતું, and in that scenario there are few other medications which were added for the management of heart rate. એટલે બીટા બ્લોકર્સ નથી તો એના જેવી કોઈ બીજી મેડિકેશન લિસ્ટમાં આવી જશે. સો ડોન્ટ વરી અબાઉટ ધેટ, યોર ફિઝિશિયન વિલ મેનેજ ધેટ પાર્ટ. અગેન ટુ રીએમ્ફેસાઇઝ ઓન ધેટ પોઈન્ટ, that હાર્ટ ફેલ્યોરમાં હાર્ટ રેટ તો ખૂબ જ અગત્યના છે, અને હાર્ટ રેટને મેનેજ 60 ની રેન્જમાં કરવાનો છે. સો don't get panic if somebody tells you that oh your heart rate is 60, your heart rate is 50, but don't worry if you are not having symptoms. તમારા symptoms નથી, that means your heart failure is very well controlled. The same way, if the patient has atrial fibrillation એટલે અનિયમિત ધબકારા થાય છે કે એરિથમિયા થાય છે, તો હાર્ટ ફેલ્યોરની ડ્રગમાં આ બે કમ્પોનન્ટ બીજા એડ થશે, જે અનિયમિત ધબકારાની મેડિકેશન એડ થશે, અને એન્ટી એરિથમિક એટલે કે બીજા કોઈ પ્રકારનું એબનોર્મલ પેટર્ન છે રિધમની, એના માટેની ડ્રગ એડ થશે. તમને હાર્ટનો પ્રોબ્લેમ નળીઓના બ્લોકેજને લીધે થયેલો છે, દેટ મીન્સ હાર્ટ ફેલ્યોર ઇઝ બીકોઝ ઓફ કોરોનરી આર્ટરી ડિઝીઝ, they'll add antiplatelet, either aspirin, clopidogrel, or in combination. તમારું બાયપાસ થયેલું છે અને પછી હાર્ટ ફેલ્યોર persistent છે, તો they'll add both the medications. Same way, statins, because you are diabetic and lipid management is a cornerstone, એ ફરીથી તમને coronary artery disease ના થાય. So these are the basic drugs which are there in the management of heart failure. Now we'll go beyond that, and I'll just briefly highlight, give information if what if the symptoms are not controlled on that part. So these medications are these given for the symptom control and prevention of repeated hospitalization. Now, with that also the symptoms are persistent, we look for the compliance of the drug. એટલે compliance એટલે patient regularly લે છે કે નથી લેતું, એમાં iron deficiency, anemia છે કે નહીં. If that is there, we try to correct that. If the patient is on other medication which causes heart failure or precipitate the symptoms, we'll try to remove this medication. We'll look at the echo, કે ઇકોની અંદર બીજું કંઈક નવું પ્રોબ્લેમ રાઇઝ નથી થતો, જેમ કે વાલ લીકિંગ વધે છે, વાલ સાંકડો થતો છે. ઇફ જે વાલ સાંકડો થાય છે, એઓર્ટિક સ્ટેનોસિસ આવે છે, ટ્રાય ટુ મેનેજ ધેટ વિથ વેરિયસ સર્જિકલ મોડાલિટીઝ ઓર નાઉઅડેઝ પરક્યુટેનિયસ મેનેજમેન્ટ, એટલે કે પગની નસમાંથી જેમ એન્જિયોપ્લાસ્ટી કરે છે એમ વાલ પણ મૂકી શકાય છે. સેમ વે તમારું વાલ લીક કરે છે અને વાલનું રિડક્શન કરવું છે અને સર્જરી ઓપન હાર્ટ પોસિબલ નથી, વિલ ઓલ્સો હેવ અ થેરાપી ધેટ વિલ રિડ્યુસ ધ વાલ લીકિંગ. તમારા ECGમાં various type of abnormality, bundle branch block છે, ECG are widened up, then there are specific devices which are available that are called as CRT-D or CRT-P. They also been advised to various patients, and with that also the patient is not getting control, or over a period the heart pumping is going down and down, or in some patients there is acute heart failure and this drug you don't have a chance, hypotension છે, ધબકારા વધારે છે, ઇન્ટ્યુબેટ કરેલું છે એટલે એને ઓરલ મેડિકેશન આપી શકાતી નથી ને ઇન્જેક્ટેબલ પ્રિપેરેશન નથી આવતું, એવામાં તમે આ કોવિડ ફેઝમાં યુ હર્ડ that there is various devices which have been used, that is ECMO if you have a lung and heart pathology both. So that generally we use in acute conditions like acute myocarditis, covid myocarditis, acute heart failure, fulminant heart failure, અને એવા જ જેવા જ બીજા વેન્ટ્રિકલને સપોર્ટ કરવાના ડિવાઇસીસ છે જેને આપણે વેન્ટ્રિક્યુલર અસિસ્ટેડ ડિવાઇસ કહીએ છીએ. For temporary support, we have various devices, as I mentioned, that ranges from 7 to 14 days સુધી તમે એને use કરી શકો to almost 6 months, 9 months to or a destination therapy કે જે કદાચ permanently તમે એને therapy offer કરી શકો છો અને heart transplant ના થઈ શકતું હોય તો. So Impella કરીને એક device છે which is now available in India, અને એ ઓલમોસ્ટ 2.5 to 5 લીટર સુધી તમારું હાર્ટનું પમ્પિંગ વધારી આપે છે. સો એ 14 to 21 days maximum you can put. So acute condition હશે, ઇન્ફ્લામેટરી હશે, હાર્ટ એટેક હશે, કોઈ માયોકાર્ડિટિસ હશે, તો એવો તમને હાર્ટનો સપોર્ટ આપશે. બાય ધ ટાઈમ ધ હાર્ટ વિલ રિકવર and you remove that device. તમને એવું લાગે છે કે now the need is for more period, you have various devices like Jarvik 3, HeartMate 3, એ ડિવાઇસ એકદમ હાર્ટની અંદર આર્ટિફિશિયલ હાર્ટ જેવું જ કામ કરતું હોય છે, but they are too costly and there can be also bridge to transplant, એટલે કે તમારું ટ્રાન્સપ્લાન્ટનું વેટિંગ ચાલતું હોય ત્યાં સુધી તમને બ્રિજ કરીને આપશે, અથવા તો બ્રિજ ટુ ડેફિનેશન, એટલે કે આ પેશન્ટમાં શું કરવું હજુ ડિફાઇન નથી થયું અને એવામાંથી બહાર કાઢવું છે તો તમે બ્રિજ ટુ ડેફિનેશન કરી શકો, અથવા તો બ્રિજ ટુ ડેસ્ટિનેશન, એટલે કે હવે આ જ થેરાપીને તમારે કન્ટિન્યુ રાખવાની છે. ને કદાચ તમે સોશિયલ મીડિયાના માધ્યમથી કે બીજા ઘણા રિસોર્ટથી તમે સાંભળ્યું બી હશે કે આવા લોકો પોતે આવું ડિવાઇસ લઈને ફરતા હોય છે, એવા ફોટા પણ જોવા મળ્યા છે. સો ઇન્ડિયામાં નાઉ ધીસ થેરાપી ઇઝ અવેલેબલ. Of course, there are various and few centers who are doing it. They are costly, of course, but in few cases they are boon in the sense કે એક વરદાન સ્વરૂપ છે કે જેમાં પેશન્ટની યંગ પેશન્ટની લાઈફ તમે બચાવી શકો છો. અને ફાઇનલી if the patient remains in heart failure which is refractory stage D, એટલે કે recurrent admissions થાય છે, પેશન્ટના સિમ્પટમ્સ જતા નથી, તો આ હાર્ટ ટ્રાન્સપ્લાન્ટનું બી એક ઓપ્શન રહેલું છે. So with that I end my talk here and will be happy to take on any question if you have regarding this whole discussion of heart failure which was divided in 2 to 3 parts. So if any questions are there, I'll be happy to take. So what I see is that can there be any long-term complication of using this medication? So Navdeep Singh, yes. So the question is are there any side effects of this medication? And see, when you ask this question, I'll answer in two part. First of all, any medication which are started, why they were started because you have a heart failure. So for heart failure, these are the drugs which prolongs your life, reduces the death rate, and reduces the hospitalization for the heart failure. So for that indication, these drugs are started. But of course, each and every drug has their own side effects. As I mentioned, beta blocker. So beta blockers generally they can reduce the heart rate. That is one thing. Some people can have extreme weakness, fatigue. Few patients, male patients particularly, they complain of erectile dysfunction. So these are few side effects with the beta blocker. Same way, vasodilator, as I mentioned, ACE inhibitors, ARBs, and ARNI, they can cause reduction in blood pressure. They can cause renal abnormalities. So your renal parameters can alter. Your potassium levels can go up. So same thing can happen with the aldosterone antagonist, that your potassium levels can go up. And particularly diabetic elderly patients where you have renal pathology, you are diabetic, and your kidney functions are also low, this kind of side effects are generally observed in these patients. And that is why the role of physician is very important, that even though I've discussed these four medications, but your physician or your cardiologist will decide whether it will suit you or not, as per your renal parameter, your blood pressure, your diabetes, and various other parameters. So, a very good question, that side effects are there. Of course, they are there, but if they are used judiciously, considering all the factor, the side effects will be very less or minimal. So, which drugs to be avoided in heart failure? And this is a fantastic question, because many of the time I have seen that patients they come with the symptoms of heart failure, so acute decompensation, and there is an emergency visit, and you try to basically study that what must have led to a heart failure, whether it is an anemia, whether it is a concurrent infection, uh, or what. So drugs, almost it is there on 25 to 30% cases. Now, which drugs to be avoided? And important drugs are in elderly patients when they use or they self-medicate for their knee pains, particularly non-steroidal anti-inflammatory drugs. If they continue to take this medication for a prolonged period, Voveran, aceclofenac, or any other non-steroidal anti-inflammatory agents, there are chances that the heart failure will be precipitated. Same thing if you use steroid by self, or your physician has prescribed for short duration for some indication, then you fail to visit, and if the same symptoms recurs, you self medicate. And self medication, that too for a prolonged period, steroids also causes precipitation of the heart failure. Third, in diabetic patient, a drug which is called as pioglitazone, and I always emphasize this to my most of the patients, that if you are having a reduced ejection fraction and symptoms of heart failure, this diabetic medication, so that you can write down that pioglitazone is a drug which can precipitate heart failure. Thirdly, there are some drugs which are basically for patients who are suffering from cancer, doxorubicin and daunorubicin. They will give rise to sudden reduction in your heart pumping capacity. So one should always consult the onco physician, and generally the onco protocols are such that if they prescribe you this medication, they'll ask you to have repeated echo during your chemo cycles. So these chemo agents are the drug which can precipitate a heart failure. In heart failure patients, there are other drugs which they are not interfering with the pumping, but they will cause arrhythmias. And the commonest antibiotics is levofloxacin, moxifloxacin. So if that has been given and you are on heart failure medication, they will alter the potassium level. And as I mentioned, the potassium go down, you will have arrhythmia, and that will arrhythmia will precipitate heart failure. Similarly, uh, there are drugs which has to be taken per se in BPH patient, benign prostatic hyperplasia. If the patient is on BPH medications, there are chances that you will have a hypotensive episode and you will have a symptoms of heart failure. So calcium channel blockers, particularly diltiazem and verapamil, if they are used and your ejection fraction is very low, they can bring a heart failure. So these are the common drugs which are basically given to manage minor complications. As I mentioned, non-steroidal anti-inflammatory on steroids are the commonest drug I observed that people have taken, and they landed up with a heart failure. See, heart failure is basically a disease which lasts for the rest of the life. Now, again, if you have improvement which is noted in the ejection fraction or not, that needs to be evaluated. So if you have reversible cause, so there are reversible causes of heart failure also. So if you are having a reversible cause, say a thyroid disease, and you have a thyrotoxicosis, because of that you have a heart failure. If you reverse your thyroid profile, that means your reverse thyrotoxicosis, and your thyroid hormone levels becomes normal, then your heart pumping capacity improves, and in that conditions we generally continue the thyroid medication and gradually remove the heart failure medication. Same way in a patients who are having postpartum post pregnancy cardiomyopathy, and the generally in 6 months period 50% of the patients they will have a recovery from heart failure. So unless they have some comorbid conditions like hypertension, diabetes, we also try to reduce the dosage and gradually remove all the medications. Many of my patients who are having peripartum cardiomyopathy, they are now off the drugs. Same way, if you have a tachycardia induced cardiomyopathy, and tachycardia is because of persistently elevated heart rate, say irregular rhythm, or the beats which are coming from abnormal focus, and that focus if treated by various means, now we have a electrophysiological study, and you treat that, your pumping improves, then we'll remove. Same way a drug induced heart failure, as I mentioned, chemotherapeutic agents they were given, they transiently reduce your heart pumping, and the cycles are over, you have removed that medication, and then your pumping improves. In myocarditis patients also, if the heart recovery has been noted, we try to detitrate the medications. But if you have other causes like coronary artery disease, and you have permanent damage, you have idiopathic dilated cardiomyopathy, you have HOCM, you have some genetic cause which has been found, then the treatment is for the rest of the life. See, Prithvi, beta blockers, as I mentioned, they have a number of indications in medical sciences, but in heart failure patient, as I mentioned, it reduces the heart rate, it allows the heart to have proper filling so that the ventricular filling and the coronary filling improves, it reduces the burden on the heart, and that will give rise to an increase in the efficiency of the failing heart. So this is what the beta blocker do in heart failure patient. So if your medications are failing, the question is by Sweta that the medications are failing, what to be done? What is to be done? And the answer is simple, and I have already answered that question. If the medications are failing, then we try to search why they are failing. There are some causes, there are precipitating factor. We try to find out whether there is a compliance, whether there are drug interaction, whether there is problem in the absorption of the drug, whether there is iron deficiency anemia. If they all ruled out, and it is purely a structural component like valve disease which is there, valve leaking which is there, valve stenosis which is there, conduction abnormality, as I mentioned, atrial fibrillation is there, we'll try to manage that. So and that also been tried, and the cause has been ruled out, then we resort to left ventricular assisted device, and finally at the end, depending upon the patient's conditions and availability, the heart transplant option is also offered to the patient. See, hemodilution and hemoconcentration both can happen, and that depends upon whether you are on a adequate dosing or not. So, if you are taking diuretics for the management of the heart failure, if sometimes even SGLT2 take in, and you have a lot of diuretic, you will have hemoconcentration. Same way, if your failure is not well controlled and you have a lot of fluid which is there in the body, and patient basically presents with the pedal edema, as abdominal distension, and when they lie down, there will be a redistribution of fluid, and at that time the bloods are collected, you'll find some form of hemodilution. So it's true that both the conditions, dilution and concentration, can happen in a patient of heart failure. So I don't see more questions, and uh, I, I thank the audience, listeners, and friends for the enthusiastic participation, and thank you very much. And next time we'll have another topic, and that will be displayed on my Facebook page very soon, and we'll discuss in terms of the what is the disease, what are the causes of the disease, and what is to be done in a very simpler form. So thank you very much for your participation. Thank you.